Hello, esteemed master and practical class members. Before we begin, please note that this video assumes you're familiar with concepts covered in my previous lectures. I'm building on that foundation to store and connect new knowledge. If anything feels unclear or unfamiliar, I encourage you to review the earlier related videos for full understanding. In our series on sitting-related gluteal pain, we have explored many individual conditions. But today is different. Today, we are not adding another diagnosis. We are consolidating everything we have discussed into a single clinical logic that allows us to differentiate this complex pain in real clinical practice. The fundamental premise remains the same. Pain triggered by the dynamic factor of sitting. This is not static pain. And if pain appears only during sitting, we must stop reading static images and start reading mechanics. Sitting is not rest. Sitting produces load redistribution, changes in pelvic tilt, soft tissue compression, venous congestion, and neural stretch. So when pain appears only in sitting, the pain generator is interacting with posture and load, not structure alone. This is exactly why a supine MRI often looks completely normal. When we ask patients to describe or draw their pain, the depth of the pain generator becomes critical. Superficial pain, such as pain arising from cutaneous nerves, including the inferior cluneal nerve, is relatively easy to localize. Patients can point with one finger. Some can even trace a clear dermatomy. But deep pain behaves very differently. Pain arising from bone, enthesis, deep muscles, or pelvic ligaments cannot be easily mapped. Patients often say, "It's deep inside," or, "I can't really point to it." This pain presents as diffuse gluteal pain, posterior superior iliac spine dominant discomfort, or deep perineal pain. The clinical rule is simple: the deeper the structure, the less precise the pain map. This is why deep pain is so frequently misunderstood, minimized, or dismissed as nonspecific, especially by inexperienced clinicians. Pain intensity gives us another powerful diagnostic clue. When the VAS score is 7 or higher, we must always consider bone pain, neural compression, or severe inflammatory states. These are what I call the silent killers for MSK-only clinicians. Because they focus primarily on what they can palpate, they often miss these pain generators. But in pain clinics, spinal origins, discogenic pain and sacroiliac joint pain are common. Not because they are rare, but because they are more painful. That level of pain is what brings patients to us. Most sitting-related pain, however, falls into the VAS 4 to 6 range. This is the domain of tendinopathy, enthesis overload, and functional sacroiliac joint pain. And when the VAS score is 3 or lower, we do not classify it as a pain syndrome. It is awareness. Discomfort. Not pain. Pain also speaks its own language. Neural pain uses words like burning, electric, sharp, tingling, or shooting. This language suggests nerve compression or ischemic neural irritation. Somatic pain sounds different. Patients describe deep aching, dull pressure, heaviness, or soreness. This reflects pathology involving bone, enthesis, ligament, or venous congestion. In real clinical practice, many sitting pain patients speak a mixed language, because multiple pain generators often coexist within the narrow subgluteal space. To think clearly, we must also know what to exclude. Clinical reasoning advances not only by inclusion, but by intentional exclusion. We remove piriformis syndrome to avoid perpetuating clinical myths. And we exclude myofascial pain syndrome. It lacks objective diagnostic classification and relies solely on subjective tenderness. It adds noise, not precision, to our diagnostic ruler. Once this logic is established, sitting-related gluteal pain naturally organizes itself into expert-level patterns. High-intensity spinal and central pain, discogenic pain and sacroiliac joint pain, typically presents as diffuse gluteal pain or posterior superior iliac spine dominant pain. Deep subgluteal pain, such as pain from the triceps coxae or the ischiofemoral space, is felt deep inside the hip and cannot be localized with one finger. Ischial and nerve-specific pain, including hamstring tendinopathy or inferior cluneal and peroneal nerve involvement, is more regionally or linearly localized and may carry a superficial neural quality. This is not a list to memorize. It is a map that emerges naturally once the logic is understood. Now, an important warning. Musculoskeletal pain has a natural tendency to heal. If it does not heal, there are always interfering factors. Unavoidable workload, prolonged sitting, insufficient recovery. But the most underestimated factor is misguided medical advice. Aggressive stretching applied to already compensated structures repeatedly disrupts healing. What could have recovered gradually converts into a permanent chronic pain syndrome. As physicians, our responsibility is not to provoke pain in order to fix pain, but to stop this cycle. Sitting-related gluteal pain cannot be understood by MRI or ultrasound alone. It must be read through dynamic provocation, depth of pain, pain intensity, pain nature, and pain duration. Only then can we identify which pain generator actually matters. Sitting pain is not invisible pain. It is pain that appears only when we look dynamically. Thank you for watching. It is my honor to be with you. As esteemed premium members, your support greatly motivates my journey of practical pain management on YouTube. I look forward to seeing you in the upcoming videos.